This organism is bypassing our public health defenses because of a specific combination of factors. It exploits a biological quirk, a conical blind spot, and the social environment of the people it infects. TM7 first appeared in Europe in 2023 among men who recently traveled through Southeast Asia. Unlike environmental fungi that spread passively on locker room floors, TM7 requires intimate, direct skin-to-skin contact to survive and jump to a new host. Once a person is exposed, the fungus takes its time. It can incubate for anywhere from several days to a few weeks before the first physical symptoms emerge on the groin or trunk. That long incubation window means a person can feel perfectly healthy while carrying the fungus and introducing it to new social networks. Traditional hygiene measures like wiping down surfaces do nothing to stop it. A patient's first visit to a clinic often marks the beginning of a diagnostic loop. To a clinician, the physical signs of TM7 look like almost anything except a fungus. Doctors are trained to look for standard ringworm infections, which form neat, scaly circles like the one seen here. But TM7 rashes often skip this classic shape entirely, appearing instead as severe inflammatory lesions that look remarkably like eczema. This leads directly to misdiagnosis. If a doctor assumes it's standard eczema, they'll prescribe standard anti-inflammatory ointments. Applying those creams to TM7 actually feeds the inflammation and makes the infection worse. Clearing a confirmed case of TM7 takes heavy-duty intervention. Patients must take specific oral antifungal medications, like terbinafine, every single day for up to 3 months. Because the infection demands the exact opposite treatment of the conditions it resembles, the standard protocol for eczema becomes a survival mechanism for the fungus. It turns the first medical encounter into a window of opportunity for the pathogen to continue spreading. Current cases of TM7 are highly concentrated within networks of men who have sex with men. Sexually transmitted infections carry a heavy social stigma, particularly when they cause visible genital rashes. That stigma creates a massive psychological hurdle, making people hesitant to walk into a sexual health clinic for evaluation. Instead of seeking immediate care, individuals might try to wait out the rash while simultaneously meeting partners through anonymous apps. The window of exposure for the broader community stays wide open. Because sexual networks are highly interconnected, a single asymptomatic carrier with a long incubation period can unwittingly pass the fungus to multiple partners before anyone realizes a pathogen is circulating. Social stigma provides the coverage the fungus needs to operate. When the fear of judgment keeps people away from the clinic, the pathogen gains an invisible corridor to move through the community. Health departments emphasize that the risk to the general public remains low, but for those caught in an active outbreak, ignoring the symptoms risks severe scarring and rapidly expanding the infection web. The CDC is clear that TM7 does not discriminate based on identity. Anyone exposed to the fungus through close, intimate contact can catch it. If you notice a persistent, scaly, or coin-shaped rash, especially around the groin or face, do not reach for over-the-counter eczema creams. Go directly to a specialized STI or sexual health clinic and ask for a targeted evaluation. On the medical side, dermatology and sexual health clinics must strengthen their surveillance. Doctors need to look past their standard expectations of what a fungal infection should look like so they can catch these cases on day one. We stop outbreaks by stripping away the conditions they need to survive. With TM7, that means updating our clinical playbooks to catch the disguise and removing the social shame that keeps people from seeking the cure.